We are now starting on the thorax region, and there we want to talk about some of the bones and the joints, like we can see here the thoracic vertebra and then the ribs and the sternum. If we look at the embryology, we'll find that there was some mesodermal component which will give the bones in this region. As we remember, there is one axial mesoderm which is called as the notochord, and on the side of the axial mesoderm we have paraxial mesoderm which will be giving us the somites. So there will be one paraaxial mesoderm which will be giving us the somites, and those somites will be giving us the vertebra. Not only they will be giving the vertebra, but they are also giving the ribs. So the vertebra and the ribs, they are all coming from the paraaxial mesoderm. In the paraaxial mesoderm also we have the somites. The somites will form the vertebra and the ribs. Then what about the sternum? We have to remember that the sternum is developing from the lateral plate mesoderm, which can be shown here. There will be a lateral plate mesoderm also, and on the lateral plate mesoderm as well, it is the dorsal somatic region. So the dorsal and the somatic region of the lateral plate mesoderm, the one which forms the upper limb, lower limb bones, is also going to form the sternum. So sternum bone is coming from lateral plate mesoderm. In the lateral plate mesoderm also the dorsal somatic portion, which will also form upper limb, lower limb bones, and it is also going to form the sternum. Now looking at the sternum, we can see it will have certain parts. Like this is the manubrium part of the sternum, then it will have a body of the sternum, and then we have got the xiphoid process of the sternum. So here is the xiphoid process, that is the body of sternum. This is the manubrium part of the sternum that is lying anteriorly on the anterior thoracic wall, whereas the vertebra are lying on the posterior aspect. Now thoracic vertebra, they are identified by the fact that they are going to have costal facets. These ribs called costa, they are attaching to the vertebra. So vertebra will have costal facet. You will find that there are costal facets on the body of the vertebra and also on the transverse process of the thoracic vertebra. So there are costal facets on the body of the thoracic vertebra and also on the transverse process of the thoracic vertebra. So if we are talking about the ribs will be coming here and making synovial joints with the vertebra. So as the ribs are making synovial joints with the vertebra, this is posterior aspect of the rib. This will be anteriorly coming ribs, and anteriorly they'll be coming to attach to the bone sternum. So anteriorly we have the sternum, posteriorly we have the vertebra, and the ribs are attaching to the vertebra and the sternum. They're called as the vertebrosternal ribs. But this vertebrosternal ribs, we will find they are only rib number 1 to 7. They are also called as the true ribs. So true ribs are basically vertebrosternal ribs as they attach to the vertebra and the sternum, and the joints which they are making are called as costotransverse joint or costovertebral joint. And these costovertebral or costotransverse joints, they are plain synovial joint. So if we are telling that the rib number 1 to 7 are true ribs or vertebrosternal ribs attaching to the vertebra and the sternum, then what about the rest 5 ribs which are inferior? So here you can mention the rib number 1 to 7. As you count, this is the first rib, second, third, 4, 5, 6, 7. So till the 7th rib we are having the true ribs. They are called as the true ribs, or they are also called as the vertebrosternal ribs because they are attaching to the vertebra posteriorly and the sternum anteriorly. You can see the first rib here. It is attaching to the thoracic 1 vertebra posteriorly, and then it is arching coming anterior, and as it comes anterior it will be attaching to the manubrium part of the sternum with the help of costal cartilage, which is hyaline cartilage. We'll be talking more about these joints, but this is what we call vertebrosternal rib. The same first rib can be shown in the X-ray as well. This is a PA view of the chest X-ray, and you can see the spine of the thoracic vertebra. They are evident near the midline. And when we are talking about the first rib, let us say on the right side, attaching to vertebra posteriorly to the sternum anteriorly, you can demarcate it here. The first rib is coming attaching to the vertebra posteriorly and then comes anteriorly. We'll notice one thing here, that the bony part of the rib is evident in the X-ray but not the costal cartilage. So that costal cartilage, with the help of which which it is attaching to the sternum anteriorly will be not visible in the X-ray. So this is the first rib. Now what about the other ribs? Like we are telling the lower 5 ribs. The lower 5 ribs, that is rib number 8 to 12, they are called as the false ribs because they are coming from the vertebra but they are not attaching to the bone sternum. And in the false rib also you will have two categories. False ribs are either called as vertebrochondral ribs or they are called as the floating ribs. So why they are called as floating ribs and why they are called as vertebrochondral ribs? Vertebrochondral ribs are rib number 8 to 10. Like you can see, this is the rib number 8 and rib number 8 is not attaching to sternum bone directly. It was only rib number 7 which was attaching to the sternum bone directly, though of course it is attaching to sternum with the help of costal cartilage. So rib number 7 is shown here and it is having this costal cartilage. And with the help of costal cartilage, it was connected to the sternum. But that is 7th rib. That is a true rib, vertebrosternal rib, coming from vertebra and attaching to sternum. Below that, we are having the false ribs. False ribs are rib number 8 to 12, the last 5, like rib number 8 is shown here. Now, if this is rib number 8 and if you are telling it is not attaching to the sternum bone, then what is it attaching to? The costal cartilage of rib number 8 is actually attaching to the next higher rib, that is 7th rib. So this is the costal cartilage of the rib number 8 and it is not attaching to sternum bone, it is attaching to the next higher rib, that is rib number 7. And the same will happen with rib number 9 and 10 also. So rib number 8, 9, 10, which are called vertebrochondral, the name comes because they are posteriorly attaching to vertebra, but anteriorly they are not attaching to sternum, they are false ribs. They are attaching to the costal cartilage of next higher rib. So 8th rib will attach to the 7th rib. Similarly, the 9th will attach to 8th and 10th will attach to the 9th rib. Now, rib number 8 to 10 are vertebrochondral, the false ribs. What about the rib number 11 and 12? Rib number 11 and 12 are called as the floating ribs, as you can see. Rib number 11 is having no anterior attachment at all. It is just attaching to the 11th thoracic vertebra and coming anteriorly. No anterior attachment. The same happens with the 12th rib. This is the 12th rib and can be shown on the other side as well. This is the 12th rib coming attaching to the 12th vertebra posteriorly, but then it has no anterior attachment. So, rib number 11 and rib number 12, since their anterior ends are floating, they have no anterior attachment. That is why rib number 11 and 12 are called as floating ribs. And as such, they are under the category of false ribs. False ribs means rib number 8 to 12. And though they attach to vertebra, they do not attach to sternum. Hence the name false rib. Now here we have marked the first rib in the X-ray. What about the second rib? Let us do the same for second rib as well. And as you mark the second rib, it is attaching posteriorly to the thoracic 2 vertebra, the second rib with the second vertebra, and coming anteriorly it will be having this costal cartilage, and we understand that the second rib is attaching to the manubriosternal junction. So at the manubriosternal junction we have the second rib, and from there you can count downwards and lateral, second rib, third rib, fourth rib, fifth rib, like that till the 10th rib, going downward and lateral. So now you have marked the second rib in the actual bony thoracic cage. What about the second rib in the X-ray? In the X-ray, you'll find second rib is below the first rib attaching to the T2 vertebra, and then it is coming anteriorly. As you follow the rib anteriorly, you will notice the anterior end of the rib is not very clearly seen. It is stopping somewhere here because the costal cartilages are not evident on the X-ray. So this is the second rib. You'll notice one thing. When you look at the ribs on the X-ray, you'll find if the ribs are seen running horizontally, then that is the posterior ends of the rib. So these are the posterior ends of the ribs which you are seeing as they are running horizontally, as compared with the anterior ends of the rib, which will be more oblique and not reaching the midline. As I will show, this is the anterior end of the rib and it will stop somewhere here because costal cartilage is not evident on the X-ray. So this is another view of the anterior end of the rib. It stops somewhere here with no anterior appearance of costal cartilage, means they are not reaching the midline. Similarly, you can see another anterior end of the rib, which obviously will be, if this is rib number 1, look at rib number 2, this will be rib number 3, 4, 5, like that. So in a sequence, you can say this is rib number 1, rib number 2, rib number 3, rib number 4, and rib number 5, the anterior ends. And if you want to see the posterior ends, we have told posterior ends are reaching the midline and they are more horizontal, like we have already seen. This is the first rib attaching to T1 vertebra. So this will be posterior end of the second rib. Then we have the posterior end of the third rib. And then we have the posterior end of the fourth rib, posterior end of the fifth rib. And then of course there will be sixth rib, seventh rib. So posteriorly they are more horizontal and reaching the midline to articulate with the thoracic vertebra, but anteriorly they are more oblique and their anterior ends are not visible because costal cartilages are not visible on the X-ray. And now let us do one thing. Let us follow the sixth rib posteriorly as well as anteriorly. We have already counted here. This was rib number 1 posteriorly and rib number 2 posteriorly, 3, rib number 4, 5 and 6. We are now following the sixth rib posteriorly and then we will continue following it towards the anterior side. So rib number 6 coming posterior and then coming to the anterior side, and anteriorly, as we have mentioned, it will be more obliquely placed. Posteriorly they are more horizontal as compared with the anterior, which is more obliquely placed and not reaching the midline because costal cartilage is not evident in the X-ray. So this is rib number 6. We already have counted here. That was rib number 1 anteriorly and rib number 2 anteriorly, 3 anteriorly, 4, 5 and rib number 6 anteriorly. We are continuing discussing the joints in the thoracic cage region, and as you will notice, when the ribs are coming from posterior to anterior, we have mentioned they all attach to vertebra, but then anteriorly only the first 7 they were attaching to sternum, and that is why rib number 1 to 7 are vertebrosternal ribs or true ribs, whereas the lower 5 ribs, that is 8 to 12, they were called as false ribs. In the false ribs also there were 2 categories. Rib number 8 to 10 they were called as vertebrochondral because they are attaching to the chondro or the cartilage of the next higher rib. They are the false ribs, but in the false ribs we also have to include rib number 11 and 12 who have no anterior attachment. The anterior ends are just floating. So maybe it is rib number 8 to 10 or 11, 12, they are all called as false ribs. Now there is another classification. You will notice that rib number 3 to 9 are called as typical ribs because they will have typical features of the rib like the head, neck, shaft, anterior end, but that will be missing or modified in the other ribs. Like rib number 1, 2 have special features, and similarly rib number 10, 11, 12 will have special features, so they will become atypical. Or you can just remember only rib number 3 to 9 are typical ribs. Prior to that or distal to that or next to that, they are all atypical ribs. Now ribs, when they are coming from the posterior vertebra to the anterior end, they'll all have synovial joint except few. And you can just remember rib number 1 and the rib number 10. They are not having the synovial joint. As we know, rib number 10 will be articulating with the costal cartilage of the next higher rib, that is rib number 9. So joint between 10th rib and the 9th rib is not synovial. It is never synovial. It is some ligamentous joint, a fibrous joint, and it is immobile. So rib number 10 has no synovial joint and it is actually a fibrous or ligamentous joint and it is immobile. The same holds true for the first rib also. Even the first rib, when it is articulating with the sternum, it is not a synovial joint. Though it is called as fibrocartilaginous joint by most of the authors, it is the synchondrosis primary cartilage joint. But Gray's Anatomy says it is a misnomer. It is not actually a synchondrosis. According to Gray's Anatomy, it is a fibrous joint and it should be called as a synarthrosis. Means again it is not a mobile joint. So what should I do if a question comes? First rib joint, which type? What should I answer? You should say according to Gray's Anatomy, first rib joint is actually a synarthrosis. It is a fibrous joint. And what will I do if it is not in the option? If synarthrosis is not in the option, go for the next answer, which most of the authors say. Mention it is a synchondrosis. It is a fibrocartilaginous joint, but according to Gray's Anatomy, it is actually a misnomer. Otherwise, as I mentioned, except for rib number 1 and rib number 10, all the other ribs, when they are articulating all of them will have synovial joints. These are all synovial joints. So as you see, rib number 2 to 7, as they are articulating with the sternum, it will be a plain synovial joint, freely mobile joint. We need free movement because the ribs help us in respiratory movements. And not only rib number 2 to 7, but also when you are talking about rib number 6 to 9, intercostal joints, they are also synovial joints. So as we see, rib number 9 is articulating with rib number 8, intercostal joint, or 8 articulating with 7, intercostal joint, or 7 articulating with 6th intercostal joints. These intercostal joints of rib number 6 to 9, rib number 6 to 9, they are all plain synovial joint. Or simply you can remember one thing, all the ribs, they have plain synovial joints except the first one, which is a synarthrosis, and 10th one, which is again a synarthrosis only. It is a fibrous joint. And rib number 10 and rib number 1, they are immobile joint. Otherwise, from rib number 2 to 9, they are freely mobile joint, plain synovial joint. Now, what about the joints which are between the sternum, manubrium part and the body part? If we focus upon manubriosternal joint, then manubriosternal joint is a midline joint, symphysis joint, secondary cartilaginous joint. So this joint, as we say, this is a midline joint, manubriosternal joint, and that is a symphysis. Then what about the xiphisternal joint? If we focus upon xiphisternal joint, then it is actually a primary cartilage joint, which is also called as synchondrosis. So most of the authors will say xiphisternal joint is a synchondrosis or primary cartilage joint. But there are a few authors who will say even this is a symphysis joint. So as you are telling, this joint here, which is xiphisternal joint, it is actually a primary cartilage joint or synchondrosis. So xiphisternal joint is a synchondrosis, whereas manubriosternal joint is a symphysis. The diagram we are looking at is the developing embryo, and we are having one side view talking about the various arteries and the veins related to the heart, and only one side of the embryo is seen. We understand that all the vessels are paired vessels. If you have one on the right, you'll have one on the left also. But since we have taken a section in such way that only one-sided blood vessels are evident here. So let us start with the heart tube itself. This is the cardiac bulge where we will have the heart tube developing. This is the umbilical cord region, that is the tail. This is the head region, pharyngeal arches are developing, and there is a cephalocaudal folding as we understand. But then looking at the heart, we will see the heart is having one receiving end or the venous end, and that receiving end or venous end is called as sinus venosus. The blood enters the heart from the incoming or venous end, sinus venosus, and then it will be pushed into the heart tube. The outgoing channel is the truncus arteriosus. So in the heart, we will have the outgoing channel, which is called as truncus arteriosus. Truncus arteriosus will push the blood into the aortic sac then, and from the aortic sac, blood will go into dorsal aorta, which as we understand are two in number, one on right side, one on left side. Though some of these structures, they fuse in the midline to become one. Now the blood which was received by the sinus venosus passing through the heart tube and then reaching what we called as the truncus arteriosus. From the truncus arteriosus, blood is going into the aortic sac. Now from the aortic sac, how this blood is going to enter the dorsal aorta? We will find that in the head neck region where we have branchial arches, some branchial arch arteries will be developing, like the carotid arteries, the subclavian arteries, the arch of aorta. So those pharyngeal arch arteries are seen here, and blood will be passing through those arteries to enter the dorsal aorta. Now only one dorsal aorta is evident here. As we understand, there will be two dorsal aorta, and these dorsal aorta, they are continuously giving what are called as the intersegmental arteries and keep supplying the thoracic region, abdomen, pelvis region, and the lower limb region also. From the aorta only, we'll find that there are given the vitelline arteries. Vitelline arteries which will be entering the yolk sac region and supplying the yolk sac region. Basically, the yolk sac gives us the gut tube. So you are talking about the arterial supply to the gut tube. And the aorta is also giving us what is called as umbilical arteries. So distally, in the lower part of the aorta will have the umbilical arteries moving towards the placenta. So placenta is being supplied by what is called as the umbilical arteries. Now we have talked about the arteries. Let us switch over to the veins. And we will notice the placenta is sending two umbilical veins. As I'm telling, there will always be one right and left. It's a pair. But here we are seeing only one side. So now the placenta is sending the umbilical vein. And as you see, this umbilical vein, which came from the placenta, passing in the umbilical cord, will be bringing the blood into the sinus venosus, the receiving end of the heart. All the veins must send the blood back towards the heart. The sinus venosus actually receives three veins, not only umbilical vein but also the vitelline vein and the cardinal veins. So here we have seen the umbilical veins draining the placenta. What about the vitelline vein? The vitelline vein is basically draining the yolk sac and carrying the blood towards the sinus venosus, once again the receiving end of the heart tube. Now as far as the umbilical veins are concerned, they simply degenerate. They have no important remnant in the adult life. But the vitelline veins which came from the yolk sac, they do contribute to significant venous formations in the adults, like the vitelline vein. Since we understand they belong to the yolk sac is going to form the gut tube, and in the gut tube they'll be forming some veins like superior mesenteric vein, inferior mesenteric vein. Superior mesenteric for draining the midgut, inferior mesenteric for draining the hindgut. And if you're talking about their drainage, they itself drain into the portal vein. The foregut drains directly into the portal vein. So basically, vitelline vein is going to contribute to the portal vein and also the mesenteric veins. As we understand, these veins are supposed to collect the nutrients from the intestine and carry it to the liver for metabolism, and then the metabolites from the liver should reach the heart. That is why the hepatocardiac portion of inferior vena cava, which will carrying the metabolites from the liver towards the heart, the terminal portion of inferior vena cava is also contributed by the vitelline vein. So not only it forms the portal vein, it also contributes to the inferior vena cava, which is called as the hepatocardiac inferior vena cava, or the terminal portion of inferior vena cava is also contributed by vitelline vein. It is basically the portal circulation carrying the nutrients from the gut tube towards the liver, and from the liver the metabolites towards the heart. That is all the derivatives from vitelline vein. So this vitelline vein was also draining into sinus venosus in the early embryonic stage. The third set of veins which drain into the sinus venosus of the heart tube are cardinal veins. And cardinal veins are initially two in number: the anterior cardinal vein, posterior cardinal vein. Diaphragm is the boundary line. Body of the diaphragm will drain into anterior cardinal veins. Body below diaphragm drain into posterior cardinal vein. Later, the body of diaphragm will develop superior vena cava from anterior cardinal vein, and body below diaphragm will develop the inferior vena cava from posterior cardinal vein. So as you see, this is the boundary line, and above the boundary line we have the anterior cardinal vein. This anterior cardinal vein later formed the superior vena cava in the adults, draining the body of the diaphragm, but embryologically anterior cardinal vein here was draining into sinus venosus for the upper body, whereas for the lower body we have the posterior cardinal vein, body below diaphragm, draining into the posterior cardinal veins. And may it be posterior cardinal vein or anterior cardinal vein, they join together to form the common cardinal vein, and common cardinal vein then drain into sinus venosus part of the heart tube. Later we will see that the posterior cardinal vein contribute to the inferior vena cava, whereas anterior cardinal vein contribute to superior vena cava. So what are the three sets of veins which are entering the sinus venosus of the heart tube? They are cardinal veins for the body wall, vitelline vein for the yolk sac, and umbilical veins for the placenta. And let us look at the three sets of veins entering sinus venosus now from the front view. You are going to look at the baby from the front view, and then you will be focusing upon sinus venosus receiving the three sets of vein. And in this diagram, we are looking from the front view into the sinus venosus part of the heart, that is the receiving end of the heart. As we have mentioned, there will be three set of veins draining from the right and left side: vitelline, umbilical, and the cardinal veins. So as you see, this is the front view of the receiving end of the heart, the sinus venosus, and this sinus venosus is going to have two horns called as the right horn of sinus venosus, receiving some blood, and the left horn of sinus venosus, receiving some blood. And then this blood will be pushed into the heart tube upwards so that it can move into the truncus arteriosus later. But then we want to see the paired veins which are entering into this sinus venosus. We already have mentioned about the umbilical veins. We mentioned that the umbilical veins drain the placenta, and there will be right and left umbilical vein coming from the placenta, but they do not have significant contribution in the adult circulation. In fact, you can remember RR and LL. The right regresses and left is left. That means the right umbilical vein will be regressing, whereas the left umbilical vein will be left. But in the adult, again, it has no contribution as such. It is just a vestigial remnant called ligamentum teres. So ligamentum teres is the adult remnant of the left umbilical vein, and it serves no purpose as such in the adult circulation. It has importance only in the fetal circulation. And as we demonstrate these veins, you can see this is the left umbilical vein draining the placenta into the left horn of sinus venosus. And similarly, we can see there is the right umbilical vein draining the placenta into the right horn of sinus venosus, into the receiving end of the heart tube. But then, as we said, RR, the right regresses, and LL, that is the left vein, is left. And later this left umbilical vein is going to become ligamentum teres, a vestigial remnant having no purpose as such in the adult circulation. Then we also have described about the vitelline veins. For vitelline veins, we were telling that they belong to the yolk sac, and yolk sac is going to give us the gut tube, and the gut tube for absorption will be having foregut, midgut, hindgut draining into the portal vein. For example, if it is the midgut, we have superior mesenteric vein. For the hindgut, we have inferior mesenteric vein, whereas foregut drains directly into the portal venous circulation. Now, they bring the nutrients from the gut tube that will be reaching the liver via the portal vein. In the liver, we will have hepatic veins and sinusoids, and then they drain into the inferior vena cava. That inferior vena cava, or terminal portion of inferior vena cava, or you say hepatocardiac inferior vena cava, is also formed by the vitelline veins. So we have right and left vitelline vein, but remember here it is the right vitelline vein which is more important in contributing to the portal venous circulation. Left has very minimal contribution. The same can be mentioned now in the diagram. This is the gut tube, say this is the duodenum developing from the yolk sac. Yolk sac will form the gut tube, and this is the duodenum part of the gut tube. So from the duodenum or from the intestine, you will have to absorb the nutrients, and for absorbing the nutrients, we are having the right-sided vitelline vein draining into the right horn of sinus venosus, and then we have the left-sided vitelline veins, which is again carrying the nutrients into the left horn of sinus venosus. And then the blood can be pushed further into the heart tube towards truncus arteriosus. Now, these veins, which are vitelline veins, we have mentioned left has not much role in the formation of the portal venous circulation. It is the right which is having more important contribution. So it is the right-sided vitelline vein which will be contributing more towards the formation of portal vein and the inferior vena cava. Terminal portion of inferior vena cava, hepatocardiac portion of inferior vena cava develops from right-sided vitelline vein. So where exactly is that happening? You will notice that there is a structure developing which is called as septum transversum. It is actually derived from the mesenchyme, the mesoderm, and later it is going to form central tendon of the diaphragm. It is also contributing to the connective tissue of the liver, and it is going to break these vitelline veins into multiple venous channels, the hepatic sinusoids. As we are telling, this is portal venous circulation. So hepatic veins and sinusoids, they are all being derived from the vitelline vein. But then what you have to understand is septum transversum, which form the central tendon. What is piercing central tendon and then moving towards the heart is hepatocardiac portion of inferior vena cava. That is the point here as we talk about portion of inferior vena cava, that is hepatocardiac portion of inferior vena cava is developing from the right-sided vitelline vein. Even the portal vein is chiefly developing from the right-sided vitelline vein. So this part, as you see here, piercing the central tendon of diaphragm and reaching the heart will be the hepatocardiac portion of inferior vena cava contributed by right-sided vitelline vein. Then what about the body wall, the cardinal veins? As we have learnt, the body above diaphragm drains into the anterior cardinal veins. As you can see, body above diaphragm draining into the anterior cardinal veins, whereas the body below diaphragm draining into posterior cardinal vein. So body below diaphragm draining into posterior cardinal vein. And then these cardinal veins, they join to form common cardinal vein. This is common cardinal vein on the left side and that is the common cardinal vein on the right side. Now we need to remember, in the embryonic stage, they are going to contribute to superior vena cava and inferior vena cava. But then superior vena cava and inferior vena cava, they develop only on the right side of the body. You will notice superior vena cava is on the right side of midline and so is the inferior vena cava. It happens because left cardinal veins, they regress. And it is only the right cardinal veins which contribute. So you can mention here now that this is the right-sided anterior cardinal vein and this is going to contribute to superior vena cava to drain body above diaphragm. Whereas this is the right-sided posterior cardinal vein and this is going to contribute to inferior vena cava to drain the body below diaphragm. But then the cardinal veins are contributing to SVC, IVC only on the right side of the body to drain the body wall. What happens to the left-sided cardinal vein is that they regress. So what will happen if I have persisting anterior cardinal vein on the left side? If you have persisting left anterior cardinal vein, you will have double superior vena cava, which is an anomaly. Similarly, if you have persisting left-sided posterior cardinal vein, then you will have the double inferior vena cava, which is again an anomaly. Normally, they should regress. In the present diagram, we are looking at the formation of the portal vein chiefly and also the other contributions given by the vitelline vein. And this is a front view we are talking about. We already know that the yolk sac would have given us the gut tube, like shown here is the duodenum, which have come from the yolk sac. And to carry the nutrients from the yolk sac or from the gut tube, we have got the vitelline veins, right and left vitelline vein. So this is the right-sided vitelline vein and that is the left-sided vitelline vein. We have already mentioned that chief contribution is from the right side. Left-sided vitelline vein has very little contribution towards the formation of portal vein. Now during development, there will be 3 anastomoses developing between right and left vitelline vein, 2 ventral and 1 dorsal. As you can see, there are 2 ventral and 1 dorsal. Actually, this middle dorsal anastomosis is more important because it is the one which will be contributing to the formation of portal vein. You will learn that portal vein has 3 contributions. Number 1, some part of the left vitelline vein. And then the anastomosis we are talking about, which is passing dorsal to the duodenum here. This is the second contribution. And then the third contribution is from the right vitelline vein. So part of the left vitelline vein, then the middle dorsal anastomosis, and chief contribution by right-sided vitelline vein. That is how the portal vein is formed. Otherwise, these anastomoses, they are going to regress and will have very little contribution towards the portal venous circulation. So here finally you can see for portal vein formation we have got chief contribution by right-sided vitelline vein and then the middle dorsal anastomosis between the right and the left vitelline vein. And third one we have discussed, a small part from the left vitelline vein. So again we can show the three contributions. Very little contribution from the left-sided vitelline vein, then significant contribution from the middle dorsal anastomosis, and chief contribution from the right-sided vitelline vein. Now, where from are developing? These splenic veins or the mesenteric veins, may be superior or inferior mesenteric veins. They are all developing from vitelline venous system only. In the fetal circulation, it is vitelline vein, and in the adult, they are splenic vein or superior mesenteric vein. Since they are on the left side, they were draining into the left-sided vitelline vein. But all of this portal venous circulation is derived from the vitelline veins only. Here you can see now the portal vein which is formed is passing behind the first part of the duodenum to enter the porta hepatis and give the right branch, left branch. So this is the portal vein which came chiefly from the right-sided vitelline vein and is now having a relation with the first part of the duodenum, as we already have mentioned here, passing dorsal to the first part of the duodenum and then entering porta hepatis, giving right and the left branch. And one more structure you can see developing in this region. We will find that the left umbilical vein was left, and that left umbilical vein in the fetal circulation was bringing the blood from the placenta. In fetal circulation, that will be highly oxygenated blood sent by the mother through the placenta, and that high oxygen saturation in the left umbilical vein is not supposed to enter the liver, because liver is immature, does not require much blood. You have to bypass the liver. So to bypass the liver, what we use is the ductus venosus, and this ductus venosus, which is a bypass channel to bypass the liver, where the left umbilical vein can put the oxygenated blood, is also developing from the vitelline veins only. And this blood will then enter the inferior vena cava, which again we have mentioned. This is the hepatocardiac inferior vena cava, carrying the metabolites of the liver towards the heart, piercing central tendon of diaphragm. So even this structure is contributed by the right-sided vitelline vein. The terminal portion of the inferior vena cava is also contributed by right-sided vitelline vein. So may it be the inferior vena cava terminal portion, the ductus venosus, or may it be the portal vein, or may it be the mesenteric vein, splenic vein. All of these are developing from the vitelline vein. This is portal venous circulation contributed by the vitelline vein. And here in this diagram, we are focusing chiefly upon the cardinal veins. The anterior cardinal vein contributing to superior vena cava and posterior cardinal vein contributing to the inferior vena cava. But then you remember, during development, in later stages, posterior cardinal vein is regressing and its function is taken over by some of the veins. Their names will be the subcardinal veins and supracardinal veins. So now you have four names: anterior cardinal vein, posterior cardinal vein, and then you have subcardinal and supracardinal veins also. Our focus will remain chiefly on the formation of inferior vena cava in this diagram. But quickly we can look at the formation of superior vena cava as well. We already have mentioned that in the embryonic stage there were some cardinal veins. One of that was anterior cardinal vein. Anterior cardinal vein was contributing to superior vena cava. But along with that, it is also contributing to internal jugular vein, body above the diaphragm. So you can see the details are given here. These are the internal jugular veins, and then this is the superior vena cava. We have mentioned that superior vena cava will develop only on the right side, because on the left side it will regress. And if we have got the left-sided superior vena cava, then it is going to be a problem. It is called as an anomaly double superior vena cava. It is due to persistence of the left-sided anterior cardinal vein. So that we don't want. We just want the right-sided anterior cardinal vein contributing to superior vena cava. But along with that, it is also contributing to internal jugular vein to drain the head and neck region. Now that was about superior vena cava, but our chief focus should remain upon formation of inferior vena cava. Inferior vena cava, initially we have known about one vein, which was the posterior cardinal vein. But then posterior cardinal vein regresses and it has very minimal contribution to the formation of inferior vena cava. It is actually just the beginning of inferior vena cava it will contribute. So, what is the contribution of posterior cardinal vein? Can be seen in the diagram here. Only the beginning of inferior vena cava. So here, posterior cardinal vein is contributing to inferior vena cava, but only the beginning of inferior vena cava. And not only it contributes to the beginning of inferior vena cava, but also the common iliac veins. So, common iliac veins in the pelvis region, they join to form inferior vena cava, and all that is coming from the posterior cardinal vein. Some books will give another name for it, and it is called as sacrocardinal vein. As it is in the sacral region, you can also call it as sacrocardinal vein, and it is giving us the beginning of the inferior vena cava. So the same thing you can see here, the posterior cardinal vein regresses, but it does contribute to inferior vena cava, a portion of inferior vena cava, that is beginning of inferior vena cava, along with common iliac veins. In fact, the common iliac veins join to form inferior vena cava. Now, as the posterior cardinal vein was regressing, two other veins came. What are their contribution? What is the contribution of supracardinal vein now? It is also forming portion of inferior vena cava along with the azygos vein. Azygos vein is in the thorax region. So, how is it contributing there? To talk about the supracardinal vein contributing to portion of inferior vena cava, you can see the details here. The supracardinal vein contributing to inferior vena cava is the infrarenal portion of inferior vena cava, means below the kidney. So below the kidneys you have the infrarenal portion. So that infrarenal portion of the inferior vena cava is contributed by supracardinal veins. And supracardinal veins not only contribute to inferior vena cava, it is also contributing to the azygos venous system. Maybe it is the hemiazygos veins on the left thorax region or the azygos vein proper in the right thorax region. So this comes as a question. Where are these hemiazygos and azygos veins coming from in the thorax region? May it be the azygos or hemiazygos in the thorax region or the infrarenal portion of inferior vena cava, that is below the kidney, all come from supracardinal vein, and that is the same thing is written here. As we talk about supracardinal vein, it contributes to infrarenal portion of inferior vena cava and azygos venous system. Then what about the subcardinal vein? What is it contributing? Subcardinal vein will contribute to the renal portion of inferior vena cava, and also it contributes to renal vein, suprarenal vein, and the gonadal veins. They all drain into this renal portion of inferior vena cava. Can be seen better in the diagram here. We are telling the subcardinal veins, they contribute to renal segment of the inferior vena cava. So where is the renal segment in the diagram? These are the kidneys. As you can see, the right kidney, left kidney, and this is the renal portion of inferior vena cava. And we have to understand that the subcardinal vein is not only contributing to the renal portion of inferior vena cava, it is also contributing to the renal veins and also suprarenal veins, even the gonadal veins. So may it be the gonadal veins or renal veins, suprarenal veins, or the renal portion of inferior vena cava, all that is coming from subcardinal vein. And then you already know which veins form the terminal portion of inferior vena cava, the one which is also called hepatocardiac portion of inferior vena cava. And if you remember, it was the portal venous circulation, chiefly contributed by right-sided vitelline vein. So you can mention that as well. It is the right-sided vitelline vein which will form the terminal portion of the inferior vena cava, which is also called as hepatocardiac portion of inferior vena cava. So this is the hepatocardiac portion of inferior vena cava, which came chiefly from the right-sided vitelline vein. In fact, all of these veins, they will be right-sided only because inferior vena cava develops only on the right side. Then what will happen to the left-sided vitelline vein or subcardinal vein or supracardinal vein or the posterior cardinal vein? What will happen to the left-sided veins? Left-sided veins, they should disappear. If they are persisting, we will have a problem. We will have a double inferior vena cava, and that will be an anomaly. We don't want that. Inferior vena cava should be present only on the right side. So all of these names must be right-sided vitelline vein, right-sided subcardinal vein, right-sided supracardinal vein, right-sided posterior cardinal vein. There is no contribution from the left side as such. Now we want to look into the details of formation of inferior vena cava. We are looking from the front view and we can talk about the various cardinal veins. Above the diaphragm, the anterior cardinal veins, below the diaphragm, posterior cardinal vein, but posterior cardinal veins are regressing, so their place taken by the subcardinal and supracardinal veins. Let us enumerate all of them here. First, let us start with the anterior cardinal vein on the right side and the left side. So these are the anterior cardinal vein on the left and right side. Then we can also talk about posterior cardinal vein on the right side and on the left side as well. So left-sided posterior cardinal vein. We understand that the anterior posterior cardinal vein, they join to form common cardinal vein, maybe on the left side or maybe on the right side. Now, the right-sided common cardinal vein and left-sided common cardinal vein, they were draining into the right horn, left horn of sinus venosus, so that blood can be pushed into the sinus venosus through the heart tube into truncus arteriosus, as you remember. But now, our focus is basically on the formation of inferior vena cava, and we know that it is not the left-sided veins which are going to contribute, it is the right-sided veins which are going to contribute. So we started with the posterior cardinal vein, but then posterior cardinal vein in due course of time is going to regress and contributes only to the initial part of inferior vena cava. Its role is now supplemented by two more veins, and one of them is called as the subcardinal vein. So this is the subcardinal vein, which you can show on the other side also, subcardinal vein. And along with the subcardinal vein, we also develop what is called as supracardinal vein, maybe on the right side or maybe on the left side. Now, how the inferior vena cava is contributed? Number one, we have contribution from the right-sided posterior cardinal vein. And number two, we have infrarenal portion of inferior vena cava that was contributed by supracardinal vein. And then we will see that there is an anastomosis between supracardinal vein and the subcardinal vein. Then comes the renal portion of inferior vena cava, and that renal portion of inferior vena cava is contributed by subcardinal vein. Then we have an anastomosis between subcardinal vein and the right-sided Vitelline vein. As we know, the right-sided Vitelline vein will form the right-sided hepatocardiac inferior vena cava. So that is how the inferior vena cava is being contributed. Once again, we can discuss the same detail. The initial part of inferior vena cava is contributed by posterior cardinal vein, which not only forms the initial part of inferior vena cava but also right-sided iliac vein and left-sided iliac vein also. That same thing can be seen here. The right-sided common iliac vein, left-sided common iliac vein join to form the initial part of inferior vena cava, all contributed by right-sided posterior cardinal vein. And then we have got the right-sided supracardinal vein. So here it is right-sided supracardinal vein, which can be shown here, right-sided supracardinal vein. Now once you say this is the right-sided supracardinal vein, this is the anastomosis with the right-sided subcardinal vein. So this is right-sided subcardinal vein, which forms the renal segment of the inferior vena cava. So the same can be mentioned here. This is the renal portion of the inferior vena cava, and then we have got an anastomosis of the subcardinal with the right-sided Vitelline vein. This contribution is coming from the right-sided Vitelline vein, as we have discussed earlier as well. And the same can be discussed here. This is the anastomosis between the subcardinal vein and right-sided Vitelline vein. This is the right-sided Vitelline vein which is forming the hepatocardiac inferior vena cava. And eventually, as you see, if you are talking about the common iliac vein, the right and left side, or the beginning of the inferior vena cava, that is formed by the posterior cardinal vein. After that, we have supracardinal vein. Then we have got an anastomosis between supracardinal and subcardinal. This is the anastomosis region. And then we have got the subcardinal vein. Then again, there is an anastomosis of the subcardinal with the right-sided Vitelline vein, the hepatocardiac portion of inferior vena cava, and draining itself into the right atrium. So these are the contributions for the inferior vena cava, the 3 cardinal veins and 1 Vitelline vein, but all on the right side. Posterior cardinal vein, which if you remember we have discussed, also called as sacrocardinal vein. So posterior cardinal vein or sacrocardinal vein, number 1. Number 2, it is the infrarenal portion of inferior vena cava, so it is supracardinal vein. Then it is the renal portion of inferior vena cava, which is the subcardinal vein. And then it is the terminal portion of inferior vena cava, which is the right-sided Vitelline vein. Now we are going to look at one anomaly related with the formation of inferior vena cava. And here you need to identify the azygos venous system. We have taken a coronal section in the thorax region, removed the anterior thoracic wall. Now you are looking at the posterior thoracic wall. These are the vertebra, and along with the vertebra you are seeing posterior intercostal veins draining into the azygos venous system. As we understand, on the right side we'll be having a long vein which is called as the azygos vein, draining the right-sided thoracic wall into the superior vena cava. And then when we talk about the left side, then on the left side we will have the hemiazygos veins. Like you see, there will be inferior hemiazygos vein draining into the azygos venous system. Then there will be superior hemiazygos vein draining into the azygos vein. So may it be the upper hemiazygos vein or may it be the lower hemiazygos vein, they drain the left thoracic wall, but eventually they drain into the azygos vein, and azygos vein itself will drain into superior vena cava. My question to you is, where are these veins developing from? Which cardinal vein contribute to the azygos venous system? And your answer should be supracardinal veins. My next question will be, supracardinal vein contribute to which part of inferior vena cava? And your answer will be, supracardinal vein, especially on the right side, will contribute to the infrarenal portion of inferior vena cava. The inferior vena cava which lies below the kidney level. My next question is, why are you having double inferior vena cava? Why you have left-sided IVC? Because maybe the left veins did not disappear. So persistence of the left veins may result in left IVC or double IVC. So which veins are persisting? That becomes a controversy, but follow this diagram. We are having a left-sided inferior vena cava because we have persistence of left supracardinal vein. So remember this name, supracardinal vein, which contributes to infrarenal portion of inferior vena cava, and it is the same supracardinal vein which contributes to the azygos venous system also. So normally this supracardinal vein should be persisting only on the right side, contributing to infrarenal IVC, but if you have its persistence on the left side, then there is a chance of having double IVC.